Okay, welcome back. This is chapter 15, injuries to muscles and bones. What we're going to do in this particular chapter is we're going to cover everything that we need to know as first responders for any injuries that we may occur and anything that we can do from a pre-response capability to any patient that has injuries to muscles or bone. All right, so as an introduction, as an emergency medical responder or an EMR, you're going to encounter many types of musculoskeletal injuries, to include the following. Every one of these guys, fractures, dislocations, simple sprains and strains, up to head injuries, both minor and severe, potential spinal cord injuries, and chest injuries. Understanding that basic anatomy is going to be very important to, for your requirement, so that you'll know the functioning of the musculoskeletal system and how you're going to treat these kind of injuries. And you need to be able to recognize the signs and symptoms of various types of musculoskeletal injuries so that you can provide proper care. All right, so patient assessment, like we've said over and over again in every single slide set: scene size up, primary assessment, history taking, secondary assessment, and reassessment. All right, so with patient assessment of injuries, when assessing a patient who has sustained an injury to the muscles and bones, you will need to complete all 5 parts of the patient assessment sequence. So you're going to have to obviously provide a thorough scene size up of the scene. Don't get tunnel vision because the patient has an obvious injury. You need to complete all parts of the scene size up to render the scene safe and to gain as much information as you can about the patient's mechanism of injury, or MOI. Be specifically or especially careful about the following standard precautions to protect you and the patient from infectious diseases. Perform a complete primary survey to determine whether the patient has any life-threatening problems related to the airway, breathing, and circulation. It is often much more efficient and helpful to perform the primary assessment and then immediately follow with a secondary assessment, holding off on obtaining the patient's medical history. Be thorough and systematic in examining all parts of the patient. Perform a thorough sample medical history to determine whether the patient has any medical conditions that require attention. Also, then continue to reassess the patient every 15 minutes for stable patients and every 5 minutes for unstable patients. So the skeletal system consists of 206 bones. It acts as the supporting framework for the body. The specific functions of the musculoskeletal system is to support the body, to protect vital structures, and to assist with body movement, and to manufacture red blood cells. It is divided into 7 areas: the skull and the face, the spinal column, the shoulder girdle, the upper extremities, rib cage and thorax, pelvis, and the lower extremities. Here's a good diagram that you'll find in your book. It shows the skeletal system, all the different frameworks, basically to include the head, the spinal column, the shoulder girdle, the upper extremities, and the lower extremities. To include also the pelvis as well. All right, so the bones of the head include the skull and the lower jawbone. The skull is actually many bones that are fused together to form a hollow sphere that contains and protects the brain. The jawbone is a movable bone that's attached to the skull. The spine consists of a series of separate bones that we call vertebrae. It is the primary support structure for the entire body. The spinal cord, which is a group of nerves that carry messages to and from the brain, it passes through a hole in each of the vertebrae. Like I said, it is the primary support, and the spine has 5 different sections. The cervical spine, which is also known as the neck, the thoracic spine, which is the upper back, the lower spine, the sacrum, and the coccyx, which is the tailbone. There's a good representation showing you the breakdown of the different sections of the spinal column. All right, so each shoulder girdle supports an arm. It consists of a collarbone, the clavicle, and the shoulder blade, the scapula. Upper extremities consist of 3 major bones plus the wrist and the hand. The arm has 1 bone, we call that the humerus. The forearm, has 2 bones, which we call the radius and the ulna. If you'll always remember, the radius is on the side of the thumb. because that's where you'll find the radial artery. Therefore, the other side has to be the ulna. So the radius is always on the side of the thumb. All right, so the rib cage or the chest, or what we call the thorax. The 12 sets of ribs protect the heart, lungs, liver, and spleen. All of the ribs are attached to the spine. The upper 5 rib sets connect directly to the sternum, which we also call the breastbone. A bridge of cartilage connects the ends of the 6th rib through the 10th rib sets to each other and to also the sternum. The 11th and 12th rib sets are called floating ribs because they are not attached to the sternum. The sternum is located in the front of the chest. The pointed structure at the bottom of the sternum is called the xiphoid process. This figure shows you the rib cage and all those processes. Here is the xiphoid process here, okay? And here are the ribs on both sides, and it shows you very clearly how they attach with cartilage. That's what that blue is. It's the cartilage. Okay. All right, so the pelvis links the body and the lower extremities. The lower extremities consist of the thigh and the leg. The thigh bone is the femur. Okay, it is the longest and the strongest bone in the body. The lower leg consists of the tibia and the fibula. The tibia is the bone that's in front. Okay, it's that flat one. You know, it's called the shin bone. A lot of people refer it to as your shin. It's what you run into in the middle of the night when you don't turn the lights on and it hurts so bad. That is called the tibia, and the bone that lies behind it is called the fibula. All right, so muscular system. The muscles of the body provide both support and movement. Okay, muscles are attached to bones by tendons and cause movements by alternating contracting or shortening, and relaxing or lengthening. So contraction is to shorten. To relax the muscle is to lengthen. The musculoskeletal system gets its name from the coordination between the muscular system and the skeletal system that produces movement. Movement occurs at joints where 2 bones come together. The bones are held together by ligaments, thick bands that arise from one bone, span the joint, and insert into the adjacent bone. There are 3 types of skeletal muscles, or 3 types of muscles, period. First ones that we're talking about is voluntary. Voluntary or skeletal muscles are attached to the bone and can be contracted and relaxed by a person at will. They are responsible for the movement of the body. Then you have involuntary or smooth muscles. They are found on the inside of the digestive tract and other internal organs of the body. They are not under conscious control and perform their functions automatically. Cardiac muscles are only found in the heart. So cardiac muscles are the only ones of their type, and they're only found in the heart. All right, so there you go. This diagram shows you the different layouts. The cardiac muscle you can see here, the skeletal muscles you can see here, and then the smooth muscles you can see there. All right, so mechanism of injury. You must understand the various MOIs, that is how injuries occurs, or mechanism of injury. Musculoskeletal injuries are caused by 3 types of MOIs. The first one is direct force, the second one is indirect force, and the third one is a twisting kind of force. So these figures, or these 3 types of mechanisms of injury, cause musculoskeletal injuries. The left side is direct force or indirect, and then the right is a twisting type of force. All right, so use the information provided by the dispatch and gathered from your size up of the scene to identify possible mechanisms of injury. A word about terminology. Okay, there are many different ways to describe a patient's injuries. So use your senses of sight and touch to determine the type of injury you suspect. Listen to the information that the patient gives you. You do not have the training or tools to diagnose an injury as a physician can, but a thorough examination can lead you to what potentially has caused the injury. Although you are not expected to diagnose these injuries, the patient's signs and symptoms will lead you to suspect that a certain injury is most probable. The most important part of your job is to provide the best assessment and treatment for the patient. So let's talk about different types of injuries. Fractures. Fractures is a broken bone. It most oftenly occurs as a result of some kind of significant force. Something has happened, okay? A variety of mechanisms can cause a fracture, but usually it's that significant force that does it. Fractures are classified as either closed or open. In more common closed fractures, okay, which is the most common, the bone is not broken, the bone is broken, but there's no break in the skin. In an open fracture, the bone is broken and the overlying skin is lacerated. The open wound can be caused by a penetrating object or by the fractured bone in itself protruding through the skin. Contamination by dirt and bacteria may lead to infection in these kind of injuries. Both open and closed fractures injure adjacent soft tissues. This results in bleeding at the fracture site. Fractures can injure nearby nerves and also blood vessels as well. All right, so dislocation. A dislocation is a disruption that tears the supporting ligaments of the joint. The bone ends that make up the joint separate completely from each other and can lock in one position. Any attempts to move a dislocated joint is very, very painful. A dislocation can damage nearby nerves and blood vessels as well. All right, sprains and strains. A sprain is a joint injury caused by excessive stretching of the supporting ligaments. It can be thought of as a partial dislocation. Strains are caused by stretching or tearing of muscle. Signs and symptoms of extremities include the following: pain at the injury site. There may be an open wound, there may not be. Swelling and dislocation, and the patient's inability or an unwillingness to move that extremity. There could also be a deformity or an angulation of the extremity itself, and also tenderness or crepitus at the injury site itself. All right, so assume that all trauma patients, okay, this is standard precautions. Patients with musculoskeletal injuries may have open wounds. So assume that all trauma patients have open wounds that pose a threat for infection. Always wear approved gloves. When you're responding to a motor vehicle crash or other situations that may present a hazard from broken glass or other sharp objects, you also should be wearing heavy rescue gloves on top of your other gloves. Some first responders wear latex or nitrile gloves under the heavy rescue gloves for added protection from the bodily fluids. If the patient has active bleeding that may splatter, you should also have protection for your eyes, nose, and mouth. All right, so general patient assessment. All the steps in the patient assessment process must be carried out before focusing your attention on any injured limb. Limb injuries or extremities are not usually life-threatening unless there is excessive bleeding from an open wound. So, to stabilize the patient's airway, breathing, and circulation first. Treat the patient with the same care and consideration that you would give to a close member of your own family. Examination of the injured limb. You need to inspect the injured limb and compare it to the opposite uninjured limb. Gently and carefully cut away any clothing covering the wound itself if necessary. When you examine the limb, you may find any one of the following: an open wound, deformity, swelling, or bruising. Any one of these can be found. All right, so continue on. Tenderness is the best indicator of an underlying fracture. I'd like for you to see how he is grasping on both sides of the arm, the upper extremity. What bone is located in this area? Ready? Did anybody say it? If you said humerus, you are correct. Very good. Start at the top of each limb. Using both hands, you need to squeeze the entire limb from top to bottom in a very systematic manner. As you conduct the hands-on examination, ask the patient where it hurts the most. Okay, location of the greatest pain is probably the injury site. If the patient shows no sign of injury, Ask the patient to move the limb carefully. All right, so how do you evaluate circulation, sensation, and movement? Once you suspect limb injury, you must evaluate the circulation and the sensation of that limb. Any injury that may have associated blood vessel or nerve damage is very, very important to do this. It is essential to check circulation and sensation after any movement of the limb as well. Follow the steps in skill drill 15-1 to check for circulation, sensation, and movement in an injured extremity. All right, so all limb injuries are treated the same way in the field. Cover the open wounds with dry sterile dressing. Apply firm but gentle pressure to control any bleeding. Apply a cold pack to painful, swollen, or deformed extremities. It will help ease the pain. It will also reduce the swelling. So cold packs are very, very good. If you don't have a commercial grade cold pack, get some ice and put it in a towel. Anything to apply ice. All right, so splint the injured limb. The less movement, the better off the patient's going to be if they have an injured extremity. Okay, so splint it in place. All right, so the advantages of splinting. Okay, general principles. All limb injuries should be splinted before the patient is moved, unless the environment prevents effective splinting or if it threatens the patient's life. So don't delay getting the patient to the hospital to do splinting. Splinting is not as important as it is for any life-threatening injuries to get those patients to the hospital. Splinting does prevent the movement of broken bone ends or a dislocated joint or a damaged soft tissue. Thereby, it also reduces pain. Splinting helps to control bleeding and decreases the risk of additional damage. Splinting also prevents closed fractures from becoming open fractures during movement during transport. Remove the clothing from the injured limb and inspect the open wounds, deformity, swelling, bruising, and capillary refill. You need to check all of these guys. Note and record that pulse and capillary refill sensation and movement distal to the point of injury. You want to see and you want to make note of that and record it so you can pass that information along with to the responders. And then cover all open wounds with a dry, sterile dressing before applying the splint. Do not move the patients before splinting unless there's an immediate danger. Mobilize the joint above and the joint below the injury site. Pat all your rigid splints so it'll be much more comfortable for your patient where possible, and supporting the injury site and minimizing the movement of the limb until the splinting is completed. Splint the limb without moving it unnecessarily. So you want to try to move it as little as possible. And a good rule of thumb, when in doubt, period, whether it's a fracture or not a fracture, go ahead and splint it. All right, some material for splints, rigid splints, they're made from any kind of firm material. It can be a piece of wood, it can be a piece of plastic, it can be a rolled up magazine, it could be anything. And it's applied to the sides, the front, the back of an injured extremity. These are your common types. You can see these in your book, whether they're padded board splints, molded plastic, aluminum. There's lots of different types. All right, so here's some examples. This is a cardboard splint here with padding that's in it. It's already pre-made. It's a commercial type of device. This is your SAM splint. It's a roll of padded aluminum. This is good stuff. It's light, it's easy to carry, and provides for a really good splint. All right, so saw splints. It is the most commonly used. Most commonly used saw splints are vacuum splints, inflatable clear plastic, and air splints. They're easy to use as long as they don't get a leak in them, that kind of stuff. And these are explained to you on skill drill 15-2. We'll be going over this within your when you do your skill assessment days as well. All right, so here's a zippered air splint. Okay, the only thing that's a drawback of this, and this is why a lot of people don't use this, is that it requires you to put the pipette in your mouth and open a valve and blow it up. So not very many of these are used in the field, but it still can provide a good adequate splint. Just remember, if you're going to be putting your mouth on something, make sure that it's clear of any kind of blood or potentially infectious material. All right, so traction splints. This is for your lower extremity fractures, okay? What happens with a lower extremity fracture, it helps to create alignment by applying a constant steady pull on that extremity. Properly applying a traction splint requires two trained EMTs working together. Splinting specific injury sites, most splinting techniques require two people. It's so much easier that way. One person stabilizes the supported and supports the injured limb while the other person applies the splint. Right, shoulder girdle injuries, apply a sling made from triangular bandages and secure it to the patient's body with sling and swath. This is just a sling here, okay? Notice it does not have what we call the swath, which is this additional triangular bandage that's wrapped around the body. For like simple elbow injuries or simple wrist injuries, this might be appropriate. But if you have shoulder injuries where you don't want the arm to come away from the body, it's always good to put a swath around it. You'll be able to practice this in your skills lab as well. So shoulder dislocation, you can also place a pillow or roll blanket into the space between the upper arm and the chest wall, and then apply the sling and swath as for other shoulder injuries. Elbow injuries, don't move an injured elbow from the position in which you found it. It's just better to splint it in place. Okay, so here's an elbow injury here. Notice that they've used a pillow and 3 triangular bandages to wrap around the elbow and to secure it in place the best as possible. Forearm injuries, several splints can be used. Your air splints, your cardboard splints, SAM splints, even rolled newspapers and magazines can work for this. Follow the steps in the skill drill 15.3, 15.4, and 15.5. We'll do those in your lab assessment. Hand, wrist, and finger injuries, simple stuff. Using bulky hand dressings or a short splint works. If you have an amputated part, make sure you place those amputated parts in a sealed plastic bag and send them to the hospital with the patient. Cover all wounds with a dry, sterile dressing. Place the hand into the position of function. Position of function is very simple, just how you would normally in a relaxed position so that the fingers are relaxed. Might even put a rolled up, piece of gauze between the hands so it allows it to rest. Like it says, place a soft roller dressings into the palm, then apply a splint and secure it with a soft bandage. All right, so pelvic fractures, these can be very, very bad for your patient. You need to treat these patients for shock, okay? But do not raise the legs until the patient is on a backboard. Feel for any tenderness when you are applying, pressure in this area or you're examining your patient. You're going to squeeze in, as you can see here, on the iliac crest, squeeze in for any pain, and then also push down on the pelvis itself, as you can see here. So squeezing in and pushing down lightly. If you get pain on just one of these, don't do the other exam. This is indicated that the patient has a fracture in the pelvis. So any one sign that there's tenderness when you're doing this exam, don't just stop right there and you've got a positive injury to the pelvis. All right, so 2 types of hip injuries are commonly seen. They're dislocations and fractures. Both injuries may result from high energy trauma. Hip fractures occur at the upper end of the femur rather than the hip joint itself. These fractures often occur in elderly patients because the bone weakens and becomes more fragile with age. This is relative to osteoporosis. Fractures of the hip region usually cause the injured limb to become more shortened and externally rotated. A dislocated hip is extremely painful. The joint is usually locked with the thigh flexed and rotated inward. The knee joint is often flexed as well. So treat all hip injuries by immobilization of the hip in the position found. You can use several pillows and roll blankets, anything like that. Place the patient on a long backboard for transportation or a scoop stretcher device. Any elderly person who has fallen and reports pain in the hip, thigh, or knee should be splinted and transported to the hospital. Thigh injuries, the fractured femur is very unstable and usually produces a significant thigh deformity with much bleeding and swelling, both, whether it's an internal bleed or external bleed. These are bad. Place the patient in a comfortable position as best as possible and treat him or her for shock and call for additional personnel and equipment. After a motor vehicle crash, you may have to move patients quickly. Secure both of the patient's legs together with swaths, cravats, or bandages so that the two lower extremities are immobilized as one unit. Traction splints are the most effective way to splint a unilateral fractured femur, so a fracture only on one side. They were designed specifically for this purpose. You should know how to use a traction splint so you can assist EMS personnel in their application. Before applying a traction splint, trained EMTs align the deformed fractures by applying manual longitudinal traction. Okay, skill drill 15-6 illustrates the steps for applying the hair traction. You'll get the opportunity to practice that in lab. All right, so this figure is straightening an injured leg for splinting. The first rescuer grasps the injured leg at the knee and applies traction on the long axis of the body. That's now the top right is the second rescuer grabs the ankle. The bottom left, the second rescuer straightens the leg. And the bottom right shows the second rescuer maintaining traction by leaning backwards. All right, so splinting of knee injuries, immobilize the injured knee in the same position that you find it. If the knee is straight, use a long padded backboards or splints or some kind of long leg air splint. If there's significant deformity, place pillows, blankets, or clothing beneath the knee and secure the splint and the materials to the leg with bandages, swaths, or cravats. Secure the injured leg to the uninjured leg so it'll help it to splint it in place. And then place the patient on a backboard, scoop stretcher, whatever it is that you're going to move the patient from one place to another. All right, so leg injuries, fractures of the leg can be splinted using air splints, cardboard splints, and magazines and newspapers. Skill drill 15-7 shows how to apply an air splint to the leg. It takes two trained people to perform the skill. One person supports the leg with both hands while the other person applies the splint. You'll have the opportunity to practice that in the lab setting. Ankle and foot injuries. Fractures of the ankle and foot can be splinted with either a pillow or an air splint. Place the pillow or splint around the injured ankle or foot and tie or pin it in place. Again, 15-8 will cover this, and you'll have the opportunity to do that in the lab setting. All right, so additional considerations. Extremity injuries are not by themselves life-threatening unless excessive bleeding is present. Sometimes you may be the only trained person at the scene of an accident. So you can practice splinting until you can quickly and completely apply the principle in any situation. You can practice splinting both on a sitting person and also a prone volunteer. It takes two people to splint most limb injuries adequately. One person to stabilize and support the extremity and one person to apply the splint. So learn how the team functions as a unit during stressful situations and be prepared to work with any member of the EMS team who arrives to assist you. All right, so injuries of the head, the skull, and the brains. Severe head and spinal cord injuries can result from different kinds of trauma. These injuries are common causes of death. If not fatal, they may lead to irreversible paralysis and permanent brain damage. The human skull has two primary parts. The cranium, which is a tough four-bone shell that protects the brain, that's the front, okay? The facial bones, which give form to the face and furnish frontal protection for the brain. This is a good diagram of the two comparisons. This is the frontal, which is the face, eye sockets, nasal bone, the upper jaw, the lower jaw, and then also the cranium. All right, so mechanism of injury, MOI. Remember, we're going back to this again. Head injuries are common with certain types of trauma. Between the skull and the brain, you have the cerebral spinal fluid, the CSF. What it does, it cushions the brain from direct blows. A direct force can injure the skull and the brain inside. An indirect force can also cause injury. Spinal injury is often associated with head injury. A force of direct blows to the head is often transmitted to the spine, producing a fracture or a dislocation. All patients with head injuries must have cervical spinal immobilization to protect the spinal cord. This figure shows you the brain. It shows you here, this is your brain. Okay, this is your brain. This is the skull here, this layer right here. This is the scalp or the skin, okay? And this is the cerebral spinal fluid right here, all right? This is this blue stuff here. That's the cerebral spinal fluid that bathes the brain and keeps it in a cushioned environment. As you can see how it attaches to the spinal cord. The spinal cord, as it passes through what we call the foramen magnum, it goes down through the center of the vertebrae themselves. So that's how that works. All right, so types of head injuries. In a closed head injury, bleeding and swelling is inside of the skull, and it may increase pressure on the brain, which can lead to irreversible brain damage and possible death. An open head injury usually bleeds profusely. Severe open head injuries are serious, but not always fatal. Examine the nose, the eyes, and the wound itself to see any blood or if there's any cerebral spinal fluid seeping out. In severe cases of open head injury, brain tissue or bone may also be visible. All right, so open and closed head injuries. On the left shows a head injury that may occur in conjunction with a cervical spine injury. In the center, this is a closed type of head injury type of pattern. And then on the right is an open head injury type of pattern. You can see here, here's the open part of the skull. As you can see here, here's blunt trauma to the head, but there's no opening to the skull. And this is what we call the coup, okay, or when the head gets snapped back, okay, from the, direct force to the head, or even from direct force to the neck, causing both internal head injury, okay, or brain injury, and then possible spinal cord injury as well at the cervical spine. All right, so these are all signs and symptoms of head injury. Confusion, unusual behavior, if they're unconscious, nausea, vomiting, any blood that's coming from the ear or from the nose or from the mouth could even be possible as well. Any decrease in consciousness, and then unequal pupils. Other signs and symptoms could be paralysis and seizure, and then of course external head trauma, some scalp laceration, bleeding, bumps, bruises, those kind of things. A serious head injury may produce what we call raccoon's eyes. Raccoon's eyes is when they have the bruising underneath the eyes, and the battle signs is when they have bruising on the back side of their mandibles just behind the ear. Okay, that's what we call battle signs. Here's a good example of raccoon eyes, as you can see here. Both eyes are blackened. And then these are battle signs. This is what we were talking about. This is mastoid process. This area right here shows bruising that's definitive, right behind the ear. Those are called battle signs. Treatment. Mobilize the head in a neutral position. Number one, maintain their open airway with the jaw thrust maneuver and support the patient's breathing with oxygen if available for you. And then monitor circulation. Be prepared to perform cardiopulmonary resuscitation if necessary. You also need to determine whether blood or cerebral spinal fluid is seeping from a wound from behind the nose or the ears. Okay. Control bleeding from all head wounds with a dry, sterile dressing, and examine and treat other serious injuries, and then make sure that you're arranging for prompt, adequate treatment to the hospital as soon as possible. All right, so facial injuries are a common result of lots of different types of injuries, motor vehicle crashes, assaults, and falls. They can bleed very briskly and look really, really bad, and they may not be so bad, but usually direct pressure will manage these very, very well. Right, so airway obstruction is the primary danger in any severe facial injury. If the patient has facial injuries, you also need to suspect spinal injury as well. So treatment of the facial injuries: immobilize the head in a neutral position, maintain their open airway with a jaw thrust maneuver, and apply oxygen. Other treatments: support their breathing, monitor their circulation, and then control any bleeding. Usually, direct pressure, sterile dressing, those kind of things work. Look for and stabilize any other serious injuries. Okay, usually if they have facial injuries, there's a good possibility they may have other injuries. All right, so if these measures do not keep the airway clear, or if you're unable to control severe facial bleeding, log roll the patient on their side, keep their head and spine stable, and roll the whole body as a unit, okay, as you can see here in this diagram. So keep the head and spine in alignment by using this log roll technique, and then suction their mouth out as necessary. All right, so injuries to the spine, spinal injuries can cause irreversible paralysis. Mechanism of injuries on this could be a displaced vertebrae, swelling or bleeding that may put pressure on the spinal cord. In severe cases of spinal injury, the spinal cord may be cut or severed. If all or part of the spinal cord is cut, nerve impulses cannot travel to and from the brain. Without the conduction of these nerve impulses, the patient usually is paralyzed below that point of injury. These figures show types of spinal injuries. The left is pressure on the spinal column or the spinal cord from the swelling of a fracture. In the center is a bruising of the spinal cord by the broken vertebrae. And to the right, an injury or displacement of the fractured vertebrae. Let's take a look at that. Let's turn this off. Yeah, see, there's the displacement right here. Okay, that can cause injury. Right, so injuries to the spinal cord, high in the neck, they usually paralyze the diaphragm and results in death. Gunshot wounds to the chest or abdomen may also produce spinal cord injury at that level if it penetrates the spinal cord. Falls and motor vehicle crashes and stabbings are most common mechanism of injuries that cause spinal cord damage. Suspect any spinal injury if the patient has sustained any high energy type of trauma. All right, so other signs and symptoms, laceration, bruise, or other sign of injuries to the head, neck, or spine, and any tenderness over any place on the spine or neck. If when you're doing your palpation, your examination, they complain of pain, you might be thinking about that. Pain in the neck or spine or pain radiating to an extremity is a high probability of an injury. Extremity weakness, numbing, or paralysis or loss of movement is also an indicator of spinal injury. Loss of sensation, movement, or tingling, burning sensation in any part of the body below the neck. And then if they have loss of bowel and bladder control, that's a high indicator. So treatment, place the head and neck in a neutral position, stabilize the head, and prevent the movement of the neck the best you can. Maintain an open airway with jaw thrust maneuver. Support the patient's breathing by administering oxygen and keeping the airway open. Be sure to monitor their circulation and assess the pulse, movement, and sensation in all extremities. Examine and treat any other serious injuries. Make sure to immobilize the patient on a long or short backboard and arrange for prompt transport as soon as possible. In stabilizing the cervical spine, we're going to do that in skill drill in the lab setting for 15-9. Motorcycle and sports helmet. In most cases, helmets do not need to be removed. Helmets are frequently fitted snug to the head, so they cradle the head. They can be secured directly to the spinal immobilization device when necessary. You should remove part or all of the helmet only under two circumstances. 1, when the face mask or visor interferes with adequate ventilation or your ability to restore an adequate airway. Or 2, when the part of the motorcycle helmet interferes with ventilation. The visor should be lifted away from the face. And also in the cases of football helmet, the face guard should be removed. If you can't get it off, then it needs to come off. In most incidences, exposing the face is the issue. Follow the steps in 15-10. We'll do that in a skill setting. When the helmet is so loose that securing it to the spinal immobilization, the device will not provide adequate immobilization of the head, then you're absolutely going to remove it. That's a good rule of thumb. All right, so injuries to the chest. The chest cavity contains lungs and heart and several major blood vessels. The cavity is surrounded and protected by the chest wall, which is made up of the ribs, cartilage, and associated chest muscles. Fractures of the ribs. Even simple fractures of one rib produces a lot of pain at the site and can cause difficulty breathing. Multiple rib fractures result in significant breathing difficulty. The patient may not be able to breathe deep enough to have an adequate amounts of oxygen. Rib fractures may also be associated with an injury to the underlying organs. You can see here are rib fractures that are in more than one place. Right, this could be a significant injury. We would be relative to stating that this is a potential site of flail chest. All right, so determine whether the ribs are bruised or broken. Apply some pressure to another part of the rib. Don't touch through the point of tenderness area. The pain in the injured area indicates a bruise, crack, or fracture. If the injury is to the side of the chest, place one hand on the front of the chest and the other on the back of the chest and squeeze gently. To check an injury to front or back of the rib cage, put your hands on either side of the chest and squeeze gently. In patients with rib fractures, be alert for signs and symptoms of internal injury, particularly shock. Treatment of rib fractures, place a pillow against the injured ribs to splint them as best as possible. There's nothing we can do to treat them, even in the hospital setting. It's just identifying them and making sure that there's no internal damage to go along with that. This prevents excess movement to the patient as you prepare for transport, and administer oxygen if it's available and you're trained to use it. Now, flail chest. If 3 or more ribs are broken in at least 2 places, the injured portion of the chest wall does not move with the rest of the chest. The injured part usually bulges outward when the patient exhales and moves inward when the patient inhales. This is an example showing you that this patient has rib fractures, which are noticed as a flail segment. That flail chest decreases the amount of oxygen and carbon dioxide exchanged in the lungs, and it causes breathing problems that will progressively become worse. So again, a flail chest occurs when 3 or more ribs are broken in at least 2 places. All right, so treatment. If the patient is having difficulty breathing, do not attempt to restrict the movement of the chest while the patient is inhaling. It may be helpful to support the patient's breathing with positive pressure using a bag valve mask and then supplemental oxygen. Be sure to monitor and support the patient's ABCs and then arrange for prompt transport. All right, so penetrating wounds to the chest. If an object, such as a knife or a bullet, penetrates the chest wall, air and blood escape into the space between the lungs and the chest wall. The air and blood may cause the lung to collapse. Lung collapse greatly reduces the amount of oxygen and carbon dioxide that is exchanged and can result in death. In this figure, it shows a penetrating chest wound that may cause the patient's lung to collapse. As you can see here, all right, so there's some kind of, reason that there's a wound, okay, maybe a penetration here. There's a wound site, so the air leaks out, okay, and it goes into the pleural space, causing pressure on the lungs itself and allowing it to deflate. Now, sometimes, the external wound itself seals up and closes itself if it's not real big. So therefore, that air does trap. So the only way that we can help them out is when a paramedic comes along, we can put a needle in the chest to open or to release the air out of the chest wall itself so that the lung will reinflate. That's only done, by trained personnel such as paramedics and a physician. All right, so blood loss into the chest cavity can also produce shock. Treatment of penetrating chest wounds. The best thing is to quickly seal an open chest wound with a material that will prevent more air from entering the chest cavity. If it is more difficult for the patient to breathe after you seal the wound, uncover one corner of the occlusive dressing to see if the breathing improves. Administer oxygen if it's available and if you're trained to use it. If a knife or other object is impaled to the chest, don't remove it. Seal the wound around the object with a dressing to prevent air from entering the chest. Stabilize the impaled objects the best you can with a bulky dressing. Any chest injury that results in air leakage and bleeding requires prompt transport. Patients with severe chest injuries require rapid transport. A conscious patient with chest trauma should be placed in a sitting position to ease their breathing. Unless you must immobilize the spine or treat the patient for shock, help the patient assume whatever position makes it easier for them to breathe. If the patient heart stops, begin chest compressions regardless of whether chest injuries are present or not. All right, so a little bit of summary on this particular chapter. We've talked a lot. We've talked about musculoskeletal injuries and how they're caused by three types of MOIs, or mechanism of injuries: direct force, indirect force, and twisting force. We also talk about fractures. They can be closed, where the bone is broken, but there is no break in the skin, or they can be open, where the bone is broken and the overlying skin is lacerated. A dislocation is a disruption that tears the supporting ligaments of a joint. A sprain is a joint injury caused by excessive stretching of the supporting ligaments. And that there's three basic types of splints: rigid, soft, and then traction splints. We also talked about closed head injuries, which is a bleeding and swelling within inside of the skull, and how it increases pressure on the brain, and it could lead to irreversible brain damage. And an open injury of the head usually bleeds profusely. Airway obstruction is the primary danger in severe facial injuries. And that if you suspect a spinal injury, do not move the patient during the examination. Keep their head in neutral alignment and use jaw thrust maneuvers to keep their airway open. And then the most common chest injuries are rib fractures, flail chest, or penetrating wounds. All right, so assessment time. Congratulations, you got it done. So what's next? Go back to your JBL Navigate dashboard, do the assessment block, open your chapter assessment, to the assessment, and submit. Remember, take the assessment as many times as you like, and you need to achieve 70% or higher cumulative score for each chapter. Thanks again for your participation. If you got any questions, please email us at student@emets.net. All right, have a great day, and we'll see you next time.